Hello, everyone. Welcome back to this webinar series by EuSoMII. I'm Gennaro Danna from Legnano near Milan, Italy. I'm a neuroradiologist at ASST Ovest Milanese in the west of Milan. And I'm very happy to be here today, this afternoon in Europe, but also this morning in America or night for Asia. And I'm very happy to be here covering both sides of this webinar, because it's a joint webinar between EuSoMII and ESNR. As you probably know, I'm also in charge with ESNR as chair of a social media committee of ESNR. And today, I'm happy to be here to moderate with my partner in crime, Dr. Pinar Yilmaz, that is with me this webinar about AI tools in clinical neuroradiology. Prior to start and to give the virtual microphone to my co-moderator, thank you to our supporting sponsor, Bracco Imaging, who will support EuSoMII in this series. Now, for me, it's time to give the virtual microphone to Pinar Yilmaz.
Thank you, Gennaro. So good morning, good afternoon, or good evening, everyone. Today we have Sven Haller with us. He studied at the medical school at University of Tübingen in Germany and specialized in radiology and diagnostic neuroradiology at the University Hospital of Basel in Switzerland. Currently, he is a neuroradiologist, also in Geneva in Switzerland, with a special interest in advanced neuroimaging techniques in the domain of neurodegenerative and neurovascular diseases. He's also a visiting professor in both Sweden and China, and he has many scientific distinctions, including the precious Lucian Apple Prize award by the European Society of Neuroradiology. And today he will tell us more about AI tools in clinical neuroradiology. So the floor is yours, Sven.
Well, thanks a lot for the invitation. So I hope that you can hear me. Can you see me? Can you see the slides? Everything
yes, perfectly.
Fine. Okay, great. So thanks a lot for the kind invitation. I'm also the head of the ESNR group of AI. And what I want to do today is to give a lecture which is really very high level. So I called it AI tools in clinical neuroradiology, food for thought. So these are my disclosures, which are in fact not related to this presentation. So what I want to do today is I want to discuss things beyond the algorithm. Oftentimes, of course, lectures are focusing on different types of algorithm, but today I really want to discuss around the algorithm and make some points that are necessary for critical evaluation of clinical application of AI tools. So this is a very important point, so I want to highlight this once again. So I will not try to explain a lot of details today. The idea is really to point to things that tend to be forgotten, notably, for example, if more scientific people work in the domain of AI with maybe less exposure to patients. So before we really start, I want to start with this quote from Geoffrey Hinton, oftentimes called the godfather of neuronal networks. And you see it's almost at the date 5 years ago. And basically what he said, that in 5 years' time, radiologists will not be useful anymore. So it's almost exactly 5 years ago. I'm still working, I'm sitting in the office. I did a lot of reports today. So I think radiologists are still valid even today. And maybe the more intelligent way to use AI is not to use it to make diagnosis, but to help the radiologist. So not to replace the radiologist, but to help the radiologist. And these are just a few points of the workflow in radiology, which starts from patient record, acquisition, processing, preparation, and so on, until reporting and communication. And AI could actually be implemented in all of those stages. So you could, for example, have an AI tool that looks for the weather report. And then if you have snow, you maybe block sometimes for, I don't know, accidents or something like this. A very intelligent application, in my opinion, could be image quality enhancement. So typically this is done in the way that you take the raw image and then you make the image acquisition faster. So you go from 5.5 minutes or 5:45 to 3.5 minutes. So you see the image quality degrades, and then you put on an AI tool to enhance the image quality. So here the aim is to make imaging faster. But you could also do it in a different way. So for example, this is the 3 Tesla scanner, which is of course quite expensive and quite narrow. And this would be a very old 1 Tesla MRI machine. And here, this is just to give you an example how the AI tool can be used to enhance the image quality. So you see the left is the raw image as it comes from the 1 Tesla scanner, quite noisy. And on the right, you have the AI enhanced image. So in fact, instead of buying the new expensive machine, you could buy a cheap machine and use AI to get a good image quality. You could even do the next step, which is the super resolution, so you can really blow up the image quality, but there is a lot of processing that is being done. It's not yet at the point. So for example, here you see a lesion which appears due to the processing, and here there's a lesion that disappears due to the processing. And of course, we already have AI in use in daily practice when we use reporting using speech recognition. The main focus, of course, is some kind of diagnostics, and therefore we just want to show what already exists today. And there are a few sites that are quite useful. This is, for example, one which is quite nice, which does an overview over all existing tools. And basically every day there are new tools coming into this page. And I would say that for today in clinical neuroradiology, the majority or the biggest groups of tools that exist can be into 4 groups. One is hematoma detection for brain CT, acute hematoma detection. One would be in the context of acute stroke. So you have some kind of acute stroke assessment, for example, automatic assessment of the aspect scores. You have something in the domain of lesion segmentation, and the prime application here is multiple sclerosis for lesion segmentation. And then you have the domain of MR volumetry, notably in the domain of neurodegenerative diseases. So the workflow that we have today is you have some kind of images, and then you have the black box of AI, and then this black box will create some kind of report. And every day, the black box becomes even bigger because there are more and more algorithms and tools on the markets. And notably, the commercial tools, of course, will not even tell you exactly what is inside the box because they want to protect their property. So that means that the radiologist, who is at the right hand of this, should do decisions based on reports, which are then based on a black box, and you don't even know exactly what is happening inside. So what is happening today, you have on the one hand, you have those people who develop those tools, and then on the other side, you have the clinical radiologist. And the bridge between the two is ever increasing because you see that the number of exams even grows every day. So the radiologist has to work even more and report even more exams every day. And at the same time, the number of publications or papers and tools in AI in radiology also explode. So what are the fundamentals? And I will really not talk about this into detail. We want to look a little bit inside the black box. And I think everybody who's on the call knows this definition, so I will not repeat this about artificial intelligence and deep learning and machine learning. Every day there are new tools and new algorithm and new neural networks. And once again, the aim of this talk is not to talk about those algorithms or, for example, very commonly used UNet convolutional networks that are commonly used for image segmentation these days. So I want to really look a little bit around what is happening. So the first point here is the point between supervised and unsupervised learning. So for the supervised learning, you need some kind of ground truth. So somebody must have made an annotation of what you learn to the tool. In an unsupervised tool, you do not need an annotation of the input data. This leads to a few different differences, and one very critical one is that if you want to make a distinction between, for example, control and patient, or disease A and disease A and disease B, you need some kind of a supervised learning with annotated data set. And then you can try to segregate two groups. If, however, you do an unsupervised learning, you will cluster certain patterns, and those clusters may or may not correspond to a given disease. But you cannot, based on this, attribute one cluster directly to one disease. So that means if we discriminate machine learning into supervised and unsupervised, you have those different techniques that are available, for example, support vector machines that have been very common a few years ago, into the supervised and the unsupervised models. Now, to make this point once again, the advantage of supervised is that in general, you have a small number of data that you need for the training, and you can classify a disease. However, what you need is an expert who has annotated data. And this then raises the question, what actually is the gold standard? And of course, you will not be able to detect unexpected diseases or unexpected conditions. And the unsupervised is quite the opposite. So you can detect unexpected or unknown categories, and there is no annotation that is needed. However, in general, you would need a larger data set, and you can only detect clusters which do not necessarily correspond to a disease. Point number two, still very technical, is about feature selection. So as before, we will do only the big points here. So just to give you a few numbers, if you do a 3D-T1 scan of the brain, and a very simple standard sequence would be something like 256 times 176 voxels. So that means that in one scan, only one 3D-T1 scan, you already have 11 million voxels. And in a normal or a typical group study that is typically done in the medical domain, you maybe have 50 or 100 participants. Maybe if you have a very large study, you have even 1,000. But there's a clear disbalance between the number of voxels and the number of participants or patients. Therefore, oftentimes what is done, notably if you do not do deep learning, for deep learning it's a little bit different, but notably if it's not necessarily a deep learning tool, the first step will be some kind of feature extraction. And those features could be shapes or edges or your surfaces, or you do some kind of ICA deconvolution or something like this. However, in the end, you want to go from millions of features to hundreds or thousands to have it more balanced as compared to the number of participants that you have. And this brings us to the related problem of double dipping. So if you go from the input data to the features to the AI, actually the classification, you go from millions to hundreds or thousands into this. You can have, if you do it in a sequential way, there is a risk of an overfitting, so that would result in two optimistic results. So you should have an integrated approach that includes feature selection and the classification. Talking about validation, it's now at the more other side of the workflow. What is done oftentimes so-called cross-validation. So that means the same data set is used for the training and for the testing. The data set is, for example, split into 10 parts. Then 9 parts are used as input data set, and 1 part is used for testing. And this is repeated 10 times until each data set was used once in the test data set. This is possible. However, it has a certain risk that the results might be a little bit too optimistic. And it is actually more conservative if you have a really strict separation between a training data set and a test data set. Speaking about validation again, now more on the administrative part. So many people think, well, if I use a tool that has a label on it, which can be a CE label for the European Community or an FDA label for the United States, the user may think that this implies some kind of clinical validation. However, this is not true, necessarily true at least, and we should be aware that there are different stages of validation. So you have a verification, then you have a technical or analytical validation, and then you have clinical validation. And if we look at, for example, this paper addressing 100 commercially available tools, you can actually see that only the minority of those are really clinically validated. So they have discriminated this validation in 6 levels. So one is technical, efficacy, and so on. And then they also looked for the distribution of the validation in how many studies actually did only one MR scanner or one center or one country. And you can see that, in fact, the majority of the products which have which are commercially available, so in that study 64%, are not validated in a scientific way using a peer-reviewed publication. This is something related, also looking a little bit about the point again. And this brings us to the next related point, which are the medico-legal issues. So let's think about a tool that is supposed to detect intracranial hemorrhage. And then, of course, there will be false positives and false negatives. And if you use such a tool to triage the workflow, then once in a while, of course, you will have a patient who has intracranial hemorrhage, but has a false negative detection on the tool. It will be very low on the working list. And by the time that the radiologist does the reading of the scan, maybe there are already negative consequences for the patient. And this is a true medico-legal problem, and it's completely unsolved. It's a little bit like the problem of self-driving cars today. Okay, so let's move a little bit in another way. Let's talk about the effect of the control group. This is something that is oftentimes forgotten. So let's say you do a volumetry for hippocampus in neurodegenerative diseases, and then you compare the individual case to a reference data set to have this kind of like what you know from growth curves from children. So you know it's a 50%, and then you have 25 or something like 1 or 2 standard deviation difference. So that means if you want to do this, intrinsically in your tool, you have a control group. And the selection of the individuals of the control group will, of course, also indirectly affect the results that you get for individual patients. And for example, in the domain of neurodegenerative diseases and dementia in particular, many people use as a reference data set the so-called ADNI data set. And the problem here is that patients are extremely pre-selected, and controls, by the way, are also very highly pre-selected. So you have what I call super patients and super controls. And these define the reference data set. Now, if you have a real patient who comes in, for example, it's very obvious to have, or often to have, vascular comorbidity. We'll come back to this in a moment. These are completely excluded because you have super controls and super patients, and then your real world patient is controlled to a super control and a super patient, and that might not be very meaningful, despite the fact that the tool in itself is very nice. Now, what actually do we want to detect, and what can we detect? And this brings us to the point of inter-individual variability. So to give you one example here, once again, in the domain of dementia and neurodegenerative disease. So the normal variability of hippocampal volume within each group is around 20%. So the normal variability of hippocampal volume in control participants is 20%. However, the difference between, for example, MCI, which is the precursor state of Alzheimer in a simplified way, and the controls is only 7%. So you see that the normal inter-individual variability is 3 times higher than the disease effect that you actually want to see. And this you can also see here once again. So this is hippocampal volume and the volume loss over time. And you can clearly see the variability in each group, Alzheimer, MCI, and controls. On average, of course, the controls have higher volume than Alzheimer's disease, but for example, with this given volume, you can be in the 3 groups. What you can also see here is that the slope is higher for Alzheimer's as compared to controls. So that means the volume loss over, for example, 1 year is higher in Alzheimer's as compared to the controls. So what we can do in order to avoid the inter-individual variability is to do an intra-individual longitudinal assessment. And just to give you a few numbers here and keep this in mind, because we will have to come back to this later. So you have a volume loss, maybe something like 4% in AD over a year, only 1% volume loss in controls. So that means you have to be able to detect 3% difference in atrophy per year if you want to make the diagnosis of AD versus controls. And in fact, you don't want to discriminate Alzheimer's disease versus controls. You want to discriminate MCI versus controls, where the difference is even larger. But keep this number in mind. So it's 3% is already for advanced disease. Now we talked about the inter-individual variability. Another point that we should not forget is the fact that a disease is not necessarily linearly correlated with imaging markers that we get. And this is, for example, the so-called cognitive reserve. So we assume that we have a linear correlation between cognition and Alzheimer's disease imaging markers, for example, hippocampal atrophy. However, this is not true, and this is one of the very old classic papers from 1968 already. And in short, it will show you that on average, you need 50% of volume loss of the hippocampus for the first symptoms of cognitive decline to occur. And of course, there is an individual variability. This is something completely different. So this is now a different disease. So this is Parkinson's disease. This is a PET tracer, sorry, not PET, this is a DAT scan, so dopamine imaging. So it's a nuclear medicine technique in a different disease, but you can see the same effect. So if you want to go from stage 0, so no disease, to stage 1, so the beginning disease, you actually have a drop in around half of the tracer uptake. The other thing is that you can see you have a quite high inter-individual variability. And the next thing that you can see that over the evolution, you do not necessarily have a linear loss. So the loss of tracer activity will be more or less linear with disease duration. However, it is non-linear if you look at disease stage. And then still another point is isolated versus coexisting pathology. So still in the example of dementia, the classic view is that you have only Alzheimer's dementia or only cerebrovascular disease or only Lewy body disease. So the idea is that you have either apples or oranges. However, it is quite common that in a given patient, you have different factors at the same time. So you have a certain degree of hippocampal volume loss, indicating Alzheimer type neurodegeneration. And you have a certain degree of white matter lesion that is indicative of white matter disease. And as time goes by, you can see that the atrophy increases, so the neurodegenerative part will increase, and the neurovascular part will also increase. And this is a little bit problematic, because if you have the two diseases occurring at the same time, the effect of having both is in fact supraadditive. So stage 1, Alzheimer, and stage 1 vascular disease, to make it very simple, does not result in stage 2, but it will result in stage 2.5. So once again, the idea of apples and oranges at the same time. And this is also the evolution of this pie chart. So we think today that the majority of patients actually have some kind of mixed disease, for example, Alzheimer and vascular dementia, Alzheimer and Lewy body dementia, and so on. Related to this is an example where you have different pathologies at the same time. For example, one intraaxial lesion and one extraaxial lesion. So this was a lymphoma and that was a meningioma. Now we move back a little bit to the technical aspects and go to the scanner. So in this specific study, we just compared, for example, a set of elderly participants in the same MRI machine, same day, same head coil, same everything. And we only changed slightly the voxel resolution from 1.0 to 1.2 millimeters. And if you do this, the resulting change in the estimated volume will change around 5%. Now, remember what I told you before, that we are actually looking for volume changes that are less than 3%. So if you do have volume changes relating to different scanners, techniques that are bigger than the 3%, then you really have a problem. And remember, this was the same day, same scanner, same head coil, same everything. So this effect will be even stronger if you compare different scanner over different time. So if you compare one patient and one scanner to a disease or reference data set, what was acquired on different scanners, that may induce a bias relating to those scanners. This is one of the reasons why, for example, in the ADNI data set, we now have this phantom with the idea to calibrate the specific scanner. And I think this is really necessary if we want to do, for example, volumetric scans, that we should calibrate and certify a given MRI scanner and MRI sequence, and only then it makes sense to use this scanner to compare an individual of this scanner to a reference data set which was acquired on a different scanner. If you do this, you can actually decrease the variability, which is shown here in this ADNI data set once again. But even if you do this, just one very basic thing. So remember that dehydration is very common in the elderly. And if you just compare the volumetry between dehydrated and rehydrated elderly, so just give them something to drink or ask them not to drink for a while, this will really have a very significant change, for example, here in the estimated cortical thickness. So evidently the cortex will not decrease or increase after drinking a glass of water. It's the effect of the water concentration and so on, but this is to show you how easily you can change those measurements even on an hourly basis. Next point, many tools do not necessarily have detection of kind of artifacts, motion, and so on. So you just put into the data set, into the black box, sorry, of the AI, you put in the data set, you push the green button, it does a calculation, and then you get the result. So this is not my paper, but just a previous one showing something very typical. So in Alzheimer's dementia, you can see the enlarged temporal horn and the atrophy of the hippocampus, which is of course well known. But you can also see that the Alzheimer patient is much more fluffy than the control, because is a certain degree of motion. So in this study, we actually used the MRI as a motion detector. So we just had the patient in the scanner for a while and used the MRI as a motion detector. We didn't even look at the images, but you can see that based on the amount of motion that occurs, you can actually discriminate, for example, Alzheimer patient versus controls. Then another more technical thing is that usually if you do MRI, we have today a protocol that includes several kinds of contrasts, while most tools for AI that exist today will rely only on one specific type of image sequence or contrast. The way to integrate multiple contrast that is possible, you can do it at one level, you can do it at several levels. There are quite a few different possibilities how you can do it. So it is possible, but it is difficult. Diagnostic confidence, what does this mean? So if we do a report or a clinical assessment, we would say that a disease is possible or suspicion or probable or very likely or definite. This kind of confidence or likelihood is not necessarily included in AI tools. This point is very important for clarification. So anonymization versus coding. So many people say, well, you do this tool and you send it in an anonymized way somewhere on a cloud. And this avoids all the problems of data protection and so on. So the first point here is that anonymization is the wrong term. So if you want to do a true anonymization in the true term, you remove everything that can be used to identify a patient, and then you really remove this. So you can, for example, upload this data set for, let's say, volumetry. But then, because it is completely anonymized, you will not be able to get it back because you really do not know who this patient was. What actually is done, and what many people mean if they say anonymization, is actually coding and decoding. So instead of having the name of patient X, you make a coding, then you upload it, you do the analysis, and then using a master list, you can decode this patient and you can reattribute the identity to this specific patient. And this is very problematic for, notably for brain imaging, because in many cases we do today 3-dimensional scans. So even if you remove from the data set, name and date of birth and something like this, and you upload a data set, but it remains a 3D data set, such as this one, you can use the software that everybody of us has now in iPhones or whatever mobile phones for face recognition. And you can see that 90%, 97% of cases or data sets can be identified based on the 3D reconstruction of the face. Therefore, we now have a few of tools that do something which we call defacing, so some kind of face recognition. And there are a few of those tools illustrated here. But the problem with this is that even if you do a defacing with some of those popular software tools, you will still be able to detect around 1/3 of individuals using 3D face recognition software. And the second problem is, if you do this, there are errors that can be introduced. There may, the result actually of the, for example, volumetry may change after the face removal. So the face removal that you do in a good intention can actually result in a bias of the results that you get. And now we want to come back. This would be the last point and also the biggest one, which is the point of rule in and rule out. So I already mentioned this in the beginning. 5 years ago, Geoffrey Hinton said radiologists will not be used anymore in 5 years' time. And if you look at this paper that was recently published in Radiology, you actually could think that he was right, because this tool says basically that artificial intelligence is approaching neuroradiologist level differential diagnosis accuracy at brain MRI. And this is, of course, a little bit shocking as a neuroradiologist. So we will try to digest this and try to find what we can say against this paper. So these are the area under the curve for radiologists and the AI algorithm. And you can actually see that the area under the curve of the AI tool is really the best, even better than academic neuroradiologists for the top 1 diagnosis, top 3 diagnosis, or top 2 diagnosis. So what can we say and how can we criticize this paper? So what can we say that, well, radiologists have still a right to live? So usually most of the AI tool papers that exist, they used only one specific MRI machine and one specific acquisition sequence. And you could argue, well, this is one sequence, and you cannot generalize it to different scanners. In this paper, that's actually very well done, because you see different MR vendors, different MRI systems. So it's really valid across a wide range of settings. The second point is oftentimes those tools that exist, they do only one disease or one diagnosis at a time. So intracranial hemorrhage versus no intracranial hemorrhage. This tool, in fact, had several diseases that were included. The selection of diseases is a little bit strange, but at least there were several diseases included. So what can we say? Now, the first point that we can say against this paper is, I would say here, because there were quite a few cases that had to be excluded because of incomplete imaging or motion or something like this. So 18%, so at least one case out of 5 cannot be analyzed with this tool, which is already quite an interesting number. The second one, and this is even more interesting here, is that all the cases have a disease, and there is no normal cases in this study. And this is very important because the single most common diagnosis that we have in imaging is luckily it's normal. So you do all these scans for, I don't know, breast screening or something like this, and in many cases fortunately the scans are negative. So the most common diagnosis is normal, and the majority of the AI tools that exist today are quite good to rule in, so they're quite good to detect anomaly, but they will not be that good to exclude anomaly or to say that something is normal. And then if we look at the tool even more in detail, we can see that actually what this tool does is some kind of, rather than a real, in my opinion, real diagnosis, it really does a segmentation. So there is a UNet segmentation done on the several different contrasts. And then the result of this is that, for example, here, a lesion which is hypo T1, hyper T2, which has a certain lesion volume, which is in a certain anatomic region. For example, here, right frontal. And then this result is sent to actually a Bayesian network. And this is now interesting because this Bayesian network was based on previous knowledge. So just a reminder, basically, this is some kind of a decision tree, as you know. So when the alarm clock was on, there is less likelihood that you slept over. And if you are less likely to have slept over, then you are more likely to catch the bus in time. And this is exactly what is happening here. So here the network was trained, or decision tree or Bayesian probabilities were trained, basically including textbooks and literature and expert knowledge. So in fact, what this study does is not what I would call a true artificial intelligence of diagnosis. It rather does some kind of lesion segmentation. And then the result of this lesion segmentation is something like this, a periventricular enhancing lesion. And then this is a book which exists already. I don't want to make any advertisement here, but basically you go for this specific pattern that you have identified, and then you see, well, the most common 3 diagnoses for this specific imaging pattern are multiple sclerosis, ADEM, and lymphoma. And this is the way how you get your diagnosis. And this study, in fact, did the same. So I would rather say it's not a really diagnosis, it's really an artificial intelligence data pre-processing as an input for a pre-configured Bayesian network. Now coming back to this, coming to the final remarks slowly, I'm a big fan of human intelligence, and I will give you this to read because it's really impressive how easily you can read this text. Give you 10 seconds to read it. Okay, so I think that everybody can read this, and this is quite an impressive, how to say it, it's a task of the brain to read this text that easily. However, of course, human intelligence is not always very intelligent, or humans are not always very intelligent. So this is clearly not the parking spot, and it will not be a good idea to be in the pool where you have electric currents here. And in my opinion, computers will be really intelligent at the time when they not do only what they're supposed to do, but when they really start to play computer games. So what is the outlook? I think you may like or not like AI tools, and you may be afraid of it or not. It doesn't matter because it's a reality. this is how the papers of AI in imaging explode. So you can embrace it or you can try to hide from it, but it's just something that is happening. This is not new. This has always been like this in radiology. So this was state of the art in 1962, so not that long ago. So where air was injected in the ventricular system, quite a dangerous and risky procedure. This was state of the art in 1973. The first CT scan with a very high dose and a very low image quality. So certainly nothing to compare with the MRI techniques we have today. This is the control room from the NASA for the way it looked in 1969 for the moon landing. This is the computer that was used at the time, which has clearly less computative capacity than what we have in our pockets, even times ago for the iPhone 5. But it doesn't mean that we use the computer power that we have today always in a very intelligent way. And history seems to repeat a little bit. So to conclude, it was really a kind of a high-level presentation. So I didn't want to explain the things in detail, but just for those people working in the domain of AI, maybe with an engineering background, making a few points of what could maybe be missed. And if you recognize maybe 1 or 2 points that I discussed today, and you say, well, actually, I could pay a little bit of more attention to those points, I'm very pleased with the result for this. And this is basically really summarizing what we want to say here, that AI tools in clinical routine should be a group approach, and it's not only the engineer who does it, it's not only the radiologist who does it, it must be an integrated group approach. We will just submit a paper which will hopefully appear soon about a practical checklist going over the majority of points which I described today, to give a very basic and practical checklist to evaluate AI tools for clinical routine. And with this, I would like to thank you for your attention, and I'm available if there are maybe some questions left.
Thank you so much, Sven, for your wonderful presentation. I also appreciate both the site at the start of the presentation, and also obviously like the model behind me, the definition of group citing a Ferrari and pit stop. I just noted also PNAR is here with us. I would like that the audience could give us some questions. I just see one question. Maybe PNAR, do you want to read it, please?
Yes, Vera Cruz Silva has a question. Which AI tools do you currently use in the clinical context?
I use tools for volume segmentation, which are, the definition of AI is already very broad. If you're most of the vendors, AI is the buzzword, and they always sell tools as AI tools. And in the end, there is not so much AI really inside. But if I answer the question in a wide range, let's say of computer-aided kind of tools, then what I really use a lot is volume measurements for volumetric tools for dementia and so on. Sometimes also lesion segmentation, notably for multiple sclerosis. I'm personally not working in the domain of acute stroke at these times, but these are typically the tools that are typically used most today. Are also used something automatic hematoma detection and automatic establishment of acute stroke, like automatic aspect scores. These are the tools that are currently used most of the time.
Thank you. Yeah, I also had a question regarding that, because you work in the clinics and you are obviously involved in science as well. So which tool would you prefer to have a head start, which could make its way or her way to the clinics?
I think in the end, it's only tools that make work easier and that you can understand, because at the end of the day, I'm supposed to make a clinical decision based on some kind of output. Mm-hmm. And I am personally responsible for that, for my conclusion. And if I cannot understand what is happening inside the box and I have to make a decision and I'm responsible for it, I mean, this is just not interesting. So understandable, what we call those like understandable AI tools, I think this is what is the most interesting one.
To make it more practical, I agree.
To make it practical, yeah.
There's another question. Pilar Lopez Ubeda asks, what do you think is the future of AI in radiology? New tools, new approaches, new cases to solve?
Well, that's a very good question, of course. I would hope, because I'm a radiologist and I have to pay my tax every year, so I hope that radiologists will not be useless. For the time being, what is a big problem is that for clinical diagnosis, the AI tools, they are not reimbursed, so they cost extra money. The radiologist still has the responsibility for it. And at the end of the day, the medical-legal situation is completely unclear. So I would say the intelligent, once again, in my opinion, the intelligent use of AI, of artificial intelligence, would be to help the radiologist and not to replace him. So for me, for what takes a lot of time are those very basic things. They are not sexy, so nobody does it, but take a lot of time. For example, a tool which would look my working day list and then would automatically try to change and upload the data from the scans, like the previous scans. That would really help. That will really change my day. But they're absolutely, totally unsexy tool. Nobody, you cannot present this on a nice congress. But for my daily workflow, if I wouldn't have to do this 100 clicks every day to look for previous scans, but if a tool could do that for me, that would be a real help for me. So I think all of those things around the radiologist, that would be nice. Improve image quality, improve workflow, improve image acquisition. And one thing that I would like to have is, for example, a really intelligent tool, which would evaluate the MR image acquisition while imaging is done. So I will try to explain this. What we do today is that patient is in the scanner, the patient moves the brain, the sequence takes 5 minutes, and the technician will recognize only after the 5 minutes that the scan was moved. And then you have to restart the scan again. So if we had a tool that could detect motion, for example, while the scan is done, and could immediately say, well, now stop and restart, that would save a lot of time. Or we could define, let's say, this is the image quality that we want. And if you have a very good patient who doesn't move at all, you can say after 2 minutes, well, now I have already enough data for my image quality that I want, and I stop the scan. And for somebody who moves around, you make it maybe a little bit longer. And in the end of the day, you get the image quality that you want without having those useless scans, and you have to repeat the scans and so on.
Yeah, I think that's an amazing point that you make there. But what we also have with a lot of AI tools at the moment, or like algorithms that are being created or being investigated, is that it's probably is going to be scanner specific and perhaps like model specific or update specific. And those are things, I guess, also difficult to harmonize. And I had a question myself also on harmonizing what your thoughts or point of view is of, you mentioned of how many pixels we can get out of one scan. So one other step I know that a few groups are working on is how to harmonize, or maybe that's even not a good word for it, to harmonize the data, or how to make it usable for not only for a specific country, hospital, scanner, but as we want the big data, how can we work better with that? What's your point of view?
That's something that, this discussion has been around for years and years, even before the advent of AI. And the problem is that you have two competing interests here. So the user would like to have a standard image quality. So depending on the MR vendor or the CT vendor and the place where you do it, you want to have the same image quality. Now, there are a few problems to this. The first is whenever you do a standardization, you have to standardize it in a way that everybody can do it. So standardization always includes going down with the quality. But at the same time, you want to have the beautiful best thing that you can do on your scanner, which is the latest scanner, which is better than the previous one. So this is in a way competitive. And the next point is that you have the different scanner vendors, and they want to sell the new machines because, and their selling point is our sequence is better than the sequence of the competitor. So from the point of the MR vendors, they have no interest to harmonize to a sequence which is of lower quality and which is the same as from the competitor. Because they want to say, well, our sequence is better than that of the competitor. And this is the way it goes. And it has been like this for I don't know how many years, and it will stay like.
And that's a good point with the Ferrari. Like we have to work into it all together. I have the same goal, I guess, to try to reach what we want. Thank you. There's another question. Teresa Nunes asks, any comments on the use of AI in improving the workflow in neuroradiologists and its impact on the actual performance of the radiologists?
But today,
can I add a simple practical example? Currently, I don't have any automatic tool to automatic labeling the vertebra at an MR lumbar spine scan. I also would like to have an apparent simple tool
for this. Yeah. Well, I can answer this question. I think what is really working now and established on most MR scanners are these kind of automatic slice positioning tools. So instead of the technician having to place, the axial and the coronal slices, you have now tools to do this, and that's working quite nicely. On the radiological side, I must say the tools that are available so far are extremely limited to increase my workflow. One example that exists, for example, is the segmentation of lesions in multiple sclerosis. But there are just two very practical problems that exist. So I have done this for several companies, and I will not talk about companies here. But if they do you the demonstration, it always works because the previous scan and the current scan are done on the same MRI machine with the same MR sequences that have this exact same names, and then they click on it, and then it compares the two scans, and it's nice. In a real world, the previous scan was done in another institution with another MR machine with another thing. So the last time when I challenged one of those vendors, even the vendor took half an hour to say to the tool which sequence name corresponds to what. So if I have to spend half an hour to get the tool to compare the scans, I must say I have done it already 10 times. And then the second is that the tools that exist today, they are not 100% perfect for the volume segmentation. So you anyway have to check what this tool did. And for me personally, I have no win in my workflow if I have to verify something that has been done before, which is not perfect, because verifying something that has been done before takes as much time as doing it myself. On top of this, you have a bias, because you are more likely to overlook a lesion which was not segmented by the tool before. So basically, this is what was done by the interns in radiology years ago. So you have an intern who looks at the scan and then presents the scan to the more advanced radiologist. But for the advanced radiologist, will be faster to make the report himself right away than discussing with the intern who has looked at the previous scan. And AI is currently at this stage, so it does something, but it's not yet there.
But in your opinion, because what you said before, I think as radiologists, we always have to have some hand in doing a check, right? Or do you totally want to skip that check with if there's an implemented AI tool?
No, I don't want to. I personally, I don't want to skip it. I mean, then I would say, then I would make myself jobless. Of course, I wouldn't like to do it, and I don't think that's the way to do it. We still have. I mean, flying a plane is much easier than doing a diagnosis, and even today on the plane we have still pilots. Although the computer could easily start and land a plane today, but we still want. We still want to have the pilot there. And I think, I mean, this was your question. I think a real, once again, to me, an intelligent way of artificial intelligence is to help the radiologist and not to replace it.
No, I agree. I think we should always be involved in that step. And that's a very nice example. I never thought about it like that as an intern and a radiologist with the AI tools and the future in having AI tools in clinics. I think as with an intern, the same thing happens with every AI tool, that we could improve that. And hopefully in the end, like for certain things, it will definitely be as a report what we get already with the volumetric things, etc., which you mentioned, as a nice report, which we can use to help our diagnosis.
And the last thing, and then I will stop, I think, but the last thing is the medical-legal landscape, which is completely unclear, notably in Europe, because every country has a different rule. And even today, I mean, there are no European guidelines that exist. Like, let's say, as an example, European guidelines for contrast agent injection. So these are European recommendations, but each country has their own radiological society, and they may or may not follow the guidelines from the European community. And in any way, the guidelines or recommendations from the European community are not legally restrictive. So, and it's the same. So if you want to do an AI tool, let's say, I don't know, volumetry for Alzheimer, you would have, for each country in the European community, you would have to negotiate it. That's, I mean, and so many examples today for COVID, as you see.
I was just going to say.
Every country has a different way of
handling COVID.
Of handling COVID. I mean, and I do not see how the European community would be in the situation to agree on something. That's just. But I'm not a politician. It's only a very
No, I don't think we should get it to the politics anyway. But I totally agree with what you said. And the first thing that popped up in my mind was, look at how COVID is being handled European wise. So I agree on that point as well. I'm not sure. Do we have any other questions? I don't see any other questions.
I think the time is over, because we have to go to the end. So I say another time thank you to Sven Haller to be with us this afternoon, this morning. And I give another time the virtual microphone to Pınar Yılmaz for the conclusions, for to give the bye-bye to everyone.
Yeah, thank you so much for this amazing presentation again. I think it was a great overview for AI in general and specific neuroradiology, which is also my interest. And I also want to thank everyone who joined us today, and of course our sponsor Braco for making this possible. Thank you, everyone. Have a great day wherever you are.
See you. Bye-bye.
Bye.